Hi, my name is Peter Piñerrera. I'm going to talk about permissive underfeeding or standard enteral feeding in critical ill adults. The definition: nutritional support is an essential component of the care of critical ill adults. Achieve, Achieving calorie targets has been recommended with the premise that attenuating malnutrition and protein catabolism, which are associated with increased morbidity and mortality, will improve outcomes.
Case Study, Enteral Nutrition by Nancy Broaddus.
A 3-month-old baby with a complete atrioventricular canal is admitted with symptoms of congestive heart failure. Mom reports that he is breathing fast and not feeding well. His oral intake for the past 24 hours is 280 milliliters of 24 calories per ounce formula. Respirations are 66 per minute. Oxygen saturation is 88% on room air. His weight is 3.7 kilograms, and that is decreased from 4 kilograms on his last clinic visit 3 weeks ago. The baby has nasal flaring and subcostal retractions.
Question 1. Now it is your turn to practice. Please calculate the daily caloric intake for this baby. Please click the Leave a Comment button now to leave your answer. Note, this will not be used as
To calculating calories.
Applications in medicine. In the past years, many studies have documented the importance of early enteral nutrition support. Endoscopy placement of post-pyloric nasoenteric feeding tube is being used more frequently to establish early reliable enteral access, and therapy allow early initiation of enteral nutrition in intensive care unit patients.
One of the big things, and Sanjay, I want you to address this if you don't mind, is early enteral nutrition postoperatively. You know, the fear, especially if you had a GI anastomosis, we can't stress the anastomoses, and you basically, the old dogma was you waited till they had bowel sounds and you gently pushed them. So, they would go 1, 2, 3, 5 days with no PO nutrition.
Yeah, and sometimes it'd be start on TPN. A week would go by, and they're like, "Well, we better put them on TPN," and nothing's come out. Yeah, I think that earlier in my training there was that, and I saw a lot of the surgeons just kind of cringing, being like, "What? They're gonna throw up. We can't feed them. They're not ready. They're not ready." And I think that I try to feed them as early as I can. I'll certainly start chewing gum right after surgery, and then usually about 4 hours, 6 hours after surgery, we'll start them on some liquids. And I think that's where patient education is key, is that if you drink something and you start feeling bloated and nauseous, don't chug another 3 liters of whatever you're drinking. I think that educating the patients about that certainly can help, because they certainly appreciate getting liquids earlier. And I do think that early feeding stimulates the gut.
Pros and cons. Additional studies have determined that the provision of specialized enteral nutrition or immunonutrition is associated with a significant reduction in the risk of developing infections, complications, and reduce the overall hospital stay in a specific group of patients with critical illness.
Thank you for kindly introduce, Chairman. Good afternoon, ladies and gentlemen. My name is Jun Sung Park from Korea. It's an honor for me to present my study. Today, I will talking about the benefit of early enteral nutrition after pancreatic duodenectomy. The rationale for early enteral feeding after gastrointestinal surgery is peristalsis of small bowel recovers of 6 or 8 hours after surgery. Moderative absorptive function is preserved even in absence of peristalsis, and direct passage of food in the gut lumen increases pancreatic blood flow and stimulates gut motility. There are many advantages for early enteral feeding after surgery, such as prevention of intestinal mucosal atrophy, preservation of normal gut flow and immune competence, and improvement of peripheral and whole body protein kinetics. Many reports show the positive result about early enteral feeding after surgery, but some pancreatic surgeons don't like early enteral nutrition because they believe that
Issues applying in Ecuador, we don't have too much information for this topic. And in conclusion, enteral feeding to develop a moderate amount of non-protein calories to critical ill adults was not associated with lower mortality than that associated with planned delivery of a full amount of non-protein calories.